Hello, everyone, and welcome to the Centre for Digital Transformation of Health's Making Digital Health Real series. This is our monthly seminar series that aims to provide a space for discussing emerging research, sharing career insights, particularly those that have been hard won from practical application on the ground in digital health, and showcase the bleeding edge of where technology is going, but also how that can make a difference on the ground in terms of changes and improvements to care. I'm Kit Huckvale. I'm the acting director of the Centre for Digital Transformation of Health, and I have the pleasure of leading the Validitron program here at the Centre, which is our research platform aiming to help people like you who may be trying to drive digital change in your organisations or through research access support and resources when you need it to either fill gaps or support evaluation. And at the centre, we're focused on a few things, but one of them is really this challenge of why digital innovations so often fail to translate or fail to scale. And we're really interested in de-risking. So if you have a project or idea where you'd love to bounce it off some folks who are working in this space, we're always here to help. But I'd like to now formally open the session. So maybe if we could move to the next slide. I'd like to acknowledge on behalf of everyone on the call and pay respect to the traditional owners on the lands on which we're all joining this call from today. For me, that's the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to elders past, present and emerging, and if there are any First Nations people on this call, you are particularly welcome today. Today, I have the great pleasure of introducing Dr. Padma Narasimhan, who is a clinician and a senior lecturer at UNSW up in Sydney. He has huge expertise in digital health and particularly in AI, and we're very fortunate to have him on the call today. I think he really is a kindred spirit with many people on this call in terms of being really focused on challenges on the ground and how digital technologies can make a difference. His research specifically focuses on leveraging technological innovations, thinking about global health challenges, particularly conditions like tuberculosis, and as well as the management of non-communicable diseases more generally. He is a fellow of the Australasian Institute of Digital Health. He's worked in a HOOD collaborating centre for e-health at UNSW, where he was the assistant director. And so, he really operates in an interesting space that involves both international collaboration, but also change on the ground in multiple health contexts. He's also a practicing clinician. We were just chatting before the call that he works in the ED at weekends. So I'm really fortunate to be able to introduce him, and I will hand over to him. We'll have a chance for questions at the end, so if you have thoughts, please gather them, and I look forward to his presentation and the discussion that follows. So welcome, Padma.
Thank you, Kit, for the lovely introduction. I hope everyone can hear me well and also can see my slides. I'm just going to go through one by one, but please feel free to stop anytime, or you can post the questions in the chat box, which I can see at the end, and then we can discuss about it. So thank you for the opportunity for presenting our work. Today's talk is about our project, which is titled TRIBOT, which is basically a multilingual AI interpreter for triage setting, and hence the name TRIBOT. And the title for today's talk is Making Translation Equitable and Safe. I also acknowledge the traditional custodians of the land which we meet today, and pay my respects to the Aboriginal and Torres Strait Islanders, past and emerging, and we recognize their connection to land, waters, and culture. And I'm deeply committed to equity and inclusion in digital health innovation, so that we bring the deep knowledge systems which have been sustained in these communities for thousands of years. And we are very quite mindful of the importance of culturally safe and accessible care for all Australians. I also want to acknowledge the large investigator team behind this work. We've got a team of more than 22 researchers, ranging from ED clinicians, triage nurses, nurse education partners across 3 different hospitals in Sydney: Bankstown, Lidcombe, Westmead Hospital, and also Prince of Wales. And we have a team of health services and implementation researchers, a large team of AI and data science, which includes NLP researchers and machine learning. And we also have been gifted with linguists, linguistic specialists, and multicultural advisors who work on this project, and of course the human-centered design and UX. So I'm really fortunate and acknowledge all of their contribution to this work. So today's journey is going to be, first, I'm going to pitch why we need uh, an AI interpreter in a setting like ED triage. And I'm going to slightly divert and talk a little bit about the current generic LLMs. And then also I'm going to talk in detail about how we have designed our TRIBOT, and then what we have done so far and how we are planning to implement in the real world. And also want to acknowledge the NHMRC Ideas grant funding, which has started this year for this project. So let's just start with some facts about triage in emergency department in Australia. In anybody would have lived in Australia for a few years, if they had any emergency, they would have gone to a emergency department, and the first point of contact after they register their name is a triage center. And emergency departments, as you could have imagined, are usually the first point of contact for many individuals accessing healthcare services. And last year, nearly 8 million emergency department visits were made, and it's projected to go up double in 5 years. So it's a very important area. It's getting busier and busier over a period of time. And in emergency department, as soon as you register, you go into an area called triage. And in triage, a nurse, whether male or female, who are trained in triage setting, they quickly ask you some questions, and then they check your vital signs. And then what they do is they assign you to a scale based on the Australasian triage scale in a category from 1 to 5, 1 being really sick, 2 being, and 5 being less sick. And they allocate, they categorize you, and that sets the pace for the rest of your healthcare services in ED. And all of this should happen in a 3 to 5 minute window. And this is where it gets tricky, because there's lots of patients waiting in the ED waiting room, and the nurses have to navigate a very high cognitive load. And we have seen that misclassification can occur, and studies have shown that this area misclassification may occur, and that leads to a lot of issues, like a cascade of issues, including delayed care. And one of the thing is called mistriage, where a sick person may get misclassified as less sick. For example, a category 1 or 2 can be misclassified into category 3, 4, or 5, and they will be seen by a doctor after like maybe 10, 15 minutes, or really a not so sick patient can be misclassified into a really sick patient, and then they will be seen by a doctor immediately, wasting resources. So what happens is care, this misclassification leads to delayed care and poor treatment outcomes, and all of that has been documented. And this is also leads to a lot of other healthcare service issues like increased cost, uh, patient dissatisfaction, and potential for mistrust in the system, and also medical legal risk for this patient. And this problem gets really, really pronounced among culturally and linguistically diverse population, where they're not fully able to express their symptoms even in a ED triad setting. We know that Australia is a multicultural country. 1 in 4 Australians uh, have been born overseas. In New South Wales, nearly 1/3 of them speak a language other than English at home. And the census shows that 3.4% of Australians do not speak English at all. So we do know that it's well documented, well proven that especially in areas like Melbourne or Sydney, it's very multicultural. And Australia represents a country where 300 languages are spoken. And in a metropolitan ED like where I work, in Southwest Sydney, the proportion often exceeds more than 50%. And to access, to support multilingual community in an emergency setting, in any healthcare service, the government, the New South Wales government, they do provide interpreter services, professional interpreters who are accredited by NATI. But usually what happens is you have to call them and then book an appointment, and then they will immediately call you back or call you back at some time, and then they'll be able to interpret it. The current guideline is that you have to use only professional interpreters. They do not suggest or recommend even family or friends or other healthcare worker who can speak this language to do the interpretation. So it's a pretty strict guidelines. You need human interpreters who are accredited by NATI to support the services. But this becomes a problem in an ED triage because the ED triage is only going to happen in 3 to 5 minutes. It's an acute, critical setting. It's complex, and it's hard for nurses to get an interpreter immediately, and then that kind of becomes an issue. So without an interpreter, all of these misclassifications occur. You don't get a good history, and all of these communication issues leads to the issues we widely discussed in the previous slide. So I often so the solution we are proposing is to use an multilingual AI interpreter in an ED triage, and so that we could alleviate some of the problems. And I get a question, which is the most frequent question I answer recently, is why do you need a new AI multilingual interpreter when the current AI tools like ChatGPT or Google Translate can do the job? So clearly, the fact that we are doing an extensive research and developing the product means that it is not suitable for healthcare setting, and we're going to talk about this in detail. So I'm a medical doctor. I don't know the nitty-gritties or the actual uh, architecture behind the large language models. I will explain to you in plain English summary from a medical person's perspective. As far as I understand how these large language models are most commonly called as, the company is called as ChatGPT or Gemini or Claude, the way these things work is they basically have extracted large amounts of um, text from all over the world, from including textbooks, internet, web-based sources, videos, music, everything. They've just gouged everything, and they have kind of assigned each of these text or words or sentences into what we call as codes or tokens, they call it as. And then they have developed sophisticated algorithms which can predict the next few words. So when you when you input something in ChatGPT, when you ask a question, when you prompt, it's basically predicting the next few words. The current LLMs or current tools which we have are phenomenally good. They have near godlike performance in predicting the next few words. That's why we think they are actually responding to a question. They are not reasoning it out. They are excellent predictors of the next few words. But they have become so sophisticated, so good, that we think they are actually making a conversation, but in fact they are actually predicting the next few words. I hope that kind of explains a little bit about how these things work. Now, why can't we use these generic LLMs for translation? Before that, generic LLMs by itself have got some inherent problems. So, if you are an AI engineer or a healthcare worker, or if you know any AI engineer or a person who has learned about these LLMs, kindly go and ask that person today, how does this LLM work, and how does this ChatGPT work, or how does this these models work? And I'm pretty sure they wouldn't be able to answer that, because even the developers of these large LLMs do not know how exactly these work. This is called, they describe this problem as black box algorithm. So they know what goes inside the model, they know what goes inside, they know, we can see the output, but we actually don't know what's happening inside. So it's a kind of like a black box. We don't know what's happening within these LLM. So we currently don't have a complete understanding of how these LLMs work, and this poses a big challenge for us. And I've given you some of these terminologies for you to take home so that you can kind of understand some of the key problems. And one of the thing is prompt injection attack. So for example, if these LLMs have something sinister embedded in a in the input, and they kind of project it outside. So you could have you could have heard about the news for in the last few weeks. A teenager committed suicide, and after chatting to ChatGPT, and some of these problems happen because of this issue called prompt injection. So I'll just give you an example. Let's say most of these LLMs are trained in English. And for example, let's say there is a poem or let's say a Shakespeare poem, which has been literally translated. And then Shakespeare says, oh, if you have a love failure, it's worth dying than living. And then one of these, uh, like a teenager, makes a prompt in these LLMs and asks, "What does Shakespeare think about my love failure?" It will actually translate that. So there's no reasoning. It just literally translates that. So all of these hidden instructions could manipulate AI response. And this becomes a problem for multilingual setting and also for a clinical setting. And then there is another problem called hallucination, which a lot of people would have understood, would know, which means that these AI systems can invent new terminologies which don't exist, and then they can create dangerous information. So that becomes a problem in a clinical setting, in a multilingual setting. And then most of these LLMs are trained on some data sets predominantly in English, and then they come from a particular setting, and which means they have systematic bias. They have unequal treatment based on the dialect, the gender, the age, the cultural background, and this creates a huge safety disparity for vulnerable and safety population. And all of these, and another problem with these LLMs is the context leakage, where if you input a private patient information, they can be exposed to, through cross conversation contamination. And then over a period of time, these LLMs deteriorate because they are trained to please the user. They may drift, and they potentially can give information which is not within the context of the problem. So all of these things are inherent within the generic LLMs. And so when you use LLM translator, you carry over these problems. And then the issue here is when they translate into languages, they carry over these problems. So the way the LLM translators work, like Google Translate or other things work, is they use the same model, same architecture. They tokenize the conversations and they completely translate. So when you talk to a translator, you feel like as if you're talking to a translator, but again, it's actually a predictor of the next few words. And that's what happening in the translator also. And this becomes, and when you use translators in a clinical setting, then you carry over all the basic problems which are in the LLMs and also some unique problems to the clinical setting. So, for example, let's say if you kind of use a generic translator in a triad setting, right? And we are using Arabic as a test language. A patient can describe sudden heaviness in chest in Arabic dialect could be different, but the LLM output could be translated as a mild chest discomfort if it doesn't understand that particular dialect or a particular context. And if you use a clinical shorthand like SOB, the LLM could translate it as crying heavily because SOB means sob, whereas in a clinical setting, it means shortness of breath. For example, in some cultural settings, they kind of tend to use certain idioms. In India, often heard that from my setting, they would describe chest pain as oh, some like elephant sitting on my chest. It could be something like that. It could be like a burning fire, which means the literal translation would lose the cultural context and symptom could be severely underestimated. And then most of these LLMs have got a preponderance towards male symptoms and they could be profiled higher than the females. So that introduces kind of a gender bias. So just to summarize, the generic LLMs and the translators cannot be used in a clinical setting, in a healthcare setting for all of these reasons. And that's why we have we are developing a tool which is safe in an emergency setting, and we're going to discuss about how we're going about that. So in terms of the safety and the workflow design, we have certain unique, innovative components in our tool, TRIBOT, which differentiates us from the regular LLMs. So TRIBOT is not just a chatbot adapted for healthcare. It is a purpose-built, clinically governed conversational AI system built for this particular issue of ED triage. So it is we are building exclusively for this ED triage, and it can't be replicated in other areas. I'll tell you more why about that. So the first important aspect is that we are developing our own clinical grounding data. So we develop our own ED triage conversations, which are clinically validated and translated by a NATI accredited Arabic interpreter, and those conversations get put in. Those are the conversations which are inbuilt into our model, and that's quite unique compared to other LLMs which have generic conversations. And we have strong, robust safety mechanisms. We have red flag detection, which will force the tribot to say, I can't interpret anymore, so I'm going to call a human interpreter. And we have an approach called human in the loop. The human in the loop oversight will be present at every stage. So the human in the loop can always stop the tribot when it's not working as per that. And we have a machine learning culturally sensitive tool. And the machine learning gives us a structured ATS recommendation based on the guidelines which are validated currently by the Australasian triad scales. And it's EHR ready, which can always be integrated into that. And we have we have a large multilingual team, linguistics team, which are helping us in translating, interpreting the conversations into culturally nuanced uh, tool, which are robust in multiple dialects of Arabic. And so we don't do literal translation. We also have these nuances and cultural adaptation inbuilt into that. And we are planning to do a sandbox environment testing with Amazon Connect, so that in future we could, if it needs to be integrated into the larger EHR, we could always do that. And the entire tool from scratch, from all the phases, uh, produce audit logs which can be audited throughout the journey of this product. And it also enables us in having a good governance structure. And there is an ongoing safety and equity monitoring present throughout the life cycle of the product. So now I'll just go through each and every phase, how we are developing this tool. We have a three-phase development approach. The first phase is we are developing a synthetic sandbox with a unique knowledge base, and training our AI model in that. And then we have, uh, once that AI model is trained and we understand the safety metrics, then with the synthetic data, we are going to take it to a simulation lab where we will simulate the actual triad scenario in a setting. And then we will stress test the AI model TRIBOT, and then understand the scoring mechanisms, and then we will fine tune the model. And then in phase three, we are taking the TRIBOT to the real life ED setting where we will do usability testing so that we can understand how it works in the real world. I'll tell a little bit about our TRIBOT synthetic sandbox, which is quite unique, which is going to become the standard for testing AI tools in clinical setting. Before you could deploy an AI tool in a healthcare setting, it needs to be purpose built and tested in a synthetic environment, and that's exactly what we are trying to do. We are trying to develop a new standard, new benchmark for AI in healthcare settings. We are calling this as Triage Agent Bench. So basically, what we are trying to do is we are trying to create 100 diverse patient scenarios comprising of all 5 ATS categories, the triads categories, and across different discrete tasks of triage, and then translate them into the Arabic multilingual dialogues, which are culturally nuanced, along with these noisy inputs. For example, in real life, you always have these noisy things, and there could be people who are jumping in. There's a noise in the ED, so you have that noisy inputs and realistic translation errors also when these things are not working, and that will be stress tested using this synthetic sandbox, and which will give us what we call as a robust score across all the test dimensions. We'll see how this AI model works in the synthetic environment using the clinically validated rubrics, and it will also give us what we call as a transparent, reproducible benchmark data set. And all of these cases will be validated by an ED specialist, triage nurse, and along with the NAT accredited translator and interpreter. We are using what we call as domain cap knowledge. This knowledge base of our TRIBOT is restricted to a particular set of guidelines. It will not act beyond the guidelines. It will be working only with the guide. If it can't understand, if it can't, if it can't produce an output beyond this guideline, it will simply say, please contact a human interpreter, or it will say, I can't understand. So it's only capped for that particular knowledge base. And there are another unique thing is called citation tagging. And all of these outputs will be linked to a source document. So we have these synthetic sandbox document where the 100, which can be expanded to 1,000 conversations. And those outputs, the TRIBOT output, will be factually claimed and linked to this particular source document. So we can always go and audit and verify it. And when the evidence is incomplete, contradictory, it will explicitly flag saying, I can't understand, I think it's beyond my area. And the system is designed for abstain and escalate. So whenever it's can't do anything, when it can't understand, when it can't produce an output, it will simply say, I can't, I can't, it's beyond my capacity. You have to contact an human interpreter. And the phase two is simulation. As I told you, we will fine tune that in phase one. We will take the fine tuned model, go to a simulation lab where it'll be real actors who will act like a triage nurse, who will act like an Arabic speaking person. I'll be an Arabic interpreter, and there'll be a noise coming out in the background, just like a triage. And we will test the AI TRIBOT either in a standalone mobile app or integrated into the EHR, and then see how it works. We will do the exact testing what we do in the phase one and try to produce the stability scores, the safety metrics, the equity metrics, and the clinician rated plausibility. And again, this will go through what we call as an iterative mechanism. So all of these TRIBOT tool will go into what we call as iterative mechanism, where every time we refine the model, it goes through this continuous improvement. But all of this will be audited, and we'll clearly know how these TRIBOT is, how we can differentiate from each of these version. And as I told you, at the final phase, we will take it to the real world setting. And at this stage, we are using Arabic as a test language, and we are going to test it in different ED sites where they have different demographies and acuity profiles. So we'll understand how well this works. It's only a usability study. It is not a clinical trial. So please understand that. So what does success look like for us? We are trying to see the benchmark performance is a 90% success rate on triage agent bench tasks across all stress conditions with less than 1% critical errors and red flag scenarios. And we would like a clinical workflow integration that reduce the documentation burden and accelerate the triage decision making. And we want equity gains for CAL population, and which means that there should be a measurable improvement in their triage experience, in their satisfaction, with no language group experiencing disproportionate errors. And the trust and transparency from the healthcare worker. Nurse should report confidence in the TRIBOT's reasoning, citing explainability and appropriate escalation as key enablers. So we are not defining technology success as, the success as technology adoption alone, but improvements in the equity, safety, and the clinician's trust measured rigorously and transparently. And as I told you before, we'll have thorough clinical audits throughout the life cycle of the project, and all of these will be documented. And will also, we feel that it will help in the understanding and the application of triage tools using AI tools in ED. Bias detection and equity targets are very important. We are very keen to understand the performance analysis by the language, age, gender, and cultural background, so that we understand not only what happens, but also how it happens, and also why it happens across these language barriers. We are working closely with a lot of agencies in New South Wales so that we could see how we could integrate the TRIBOT tool into the system. It's a complicated process, but nevertheless, with thorough platform we are building, I think it should be it should be easy for us to integrate into the existing health systems. One of the important things is we are very keen to have the human in the loop oversight. This tool is designed to support the nurses and the human interpreters. And no, we have been very particular that the AI tools are not going to replace humans in the health system, but is only going to be a support system where it supports the human interpreters, the nurses, in applying a safe and a culturally sensitive tool in an ED triage. All of our TRIBOT's life cycle is strictly governed by the national and international frameworks for AI. We have a UNSW AI framework. We have the NSW AI framework. We have the NHMRC AI framework. And our tool adheres strictly to this. And we have put through the UNSW, we have put through the TRIBOT proposal through 3 different ethics. Only with these ethical governance tools we will be developing these tools. And these are some of the benchmark we are planning to propose from benchmark to bedside. We are currently in the phase 1, and next year we're going to phase 2. And finally, in 2026, we would scale it up with a clinical trial with the other languages so that we could kind of expand the TRIBOT tool in other languages also. Our commitment is transparency and knowledge sharing. We are committed to releasing this triage agent bench as an open standard tool so that broader research and clinical community can evaluate, critique, and improve on our work so that our work becomes reproducible. There is community validation is present, and then also it drives the standard across the AI community. The key lessons we have learned so far is that benchmark accuracy is necessary, but not sufficient. You need to stress test these AI tools under adversarial and realistic conditions, especially in acute setting like ED. We need this kind of stress testing, and that's why triage agent bench is very critical. And we have ensured that human-centered design, co-design principles are present from day 1 in our project, which means that safety and equity must be co-designed, but you can't add them later so that you could embed the red flag detection, escalation, and bias auditing from day 1. And then we believe that transparency builds trust. We have made sure that all of our AI model versions have reasonable explainability. And then there is audit trails present throughout the life cycle, which we have made sure it's a non-negotiable in a healthcare setting, especially in a clinical setting. And humans remain accountable throughout. And we have made sure there is a continuous monitoring is essential for this project. These are some of the success metrics: the time to reduce triage, the under triage improvement, the nurse experience and acceptance, and the patient satisfaction. So with that, I would thank the center for giving me this opportunity.